So I'm going to be discussing a topic, surgical anatomy or anatomical surgery. Now, why do we have to master anatomy? We have to master anatomy because when we know anatomy that we are going to be of the area that we are going to be operating on, we become more efficient. When we become more efficient, our surgery becomes faster. We become more effective, which means we get better results. We become more confident, all right? Your confidence level when you're operating even in complex areas becomes better. You become a safer surgeon and a predictive surgeon. So you become a very predictable surgeon, which means you know exactly what you're going to be planning to do. And in essence, this reduces our complication risk. So what are we going to cover in anatomy in this lecture? Number one, we're going to be recognizing the key topography of the pelvis. We're going to be describing the key structures of the anterior abdominal wall, the vascular anatomy, some strategies to minimize risks to these vital structures in the pelvis, and we're going to be reviewing some techniques to safely dissect the ureter and the retroperitoneal vasculature. So what is anatomical surgery? It is application of anatomy to assist with surgery. Now, I think you know that I do lots of endometriosis surgeries, okay? Endometriosis, you all know, can cause a frozen pelvis, right? There are 3 surgeries of endometriosis I did day before yesterday. And the anatomy is completely distorted. You know that. So, when you are having a complete distortion of anatomy, unless you have your landmarks correctly marked, you can't proceed. If you proceed that way, then you're talking of risks. You understand? So, if this area is completely messed up, you go behind this area, which is in the retroperitoneum, and then attack it from there. You've understood what I'm trying to tell you? Now, that's only possible if you're very sure of the anatomy of the retroperitoneum. You know exactly where the ureter will be, the vessel will be here, there'll be a blood supply here, there'll be a nerve here. So you see what I'm trying to tell you? Before you attack the pathology, you go and secure these areas. Now that is anatomical surgery, which means you're not doing surgery and identifying anatomy as it comes. You're identifying anatomy first before you proceed with the surgical step. Are you getting the difference? So this is what I mean by anatomical surgery. You're using anatomy to assist with the surgery. And more accurate anatomical knowledge means sound surgical technique. Why is laparoscopic anatomy slightly different? It's different because of the pneumoperitoneum that we create. So it changes some things. It's different because most of the times in the pelvis, we are operating with the Trendelenburg position. You understand? So Trendelenburg position means that the pathology will change and move upwards. It moves cranial many of the times. Not pathology, the structures. So you have to keep that in mind. It is different because many times when we are doing uterine surgery, we are also using an elevator. When we're using an elevator, you're moving things away from where they are naturally situated. So this we have to understand. We have to understand that on a screen, the structure that is up here, superior, is actually anterior in the patient. The structure that is down here is actually posterior in the patient. Okay? The structure that is this side when you're looking at the pelvis is right and this side is left. So you have to know that when you're proceeding. Otherwise, you get confused on how to proceed. When you're dissecting in laparoscopy or in any surgery, you have to understand that there is what is seen in front of you and then what is hidden behind. If you're not careful, you are risking as you're proceeding. So what I mean is you're touching the lateral wall, but remember the lateral wall is covered by peritoneum. And under the peritoneum comes the major things, the major vessels, the ureter, the nerves, You understand? The lymph nodes. So basically, if you are not, that is the unseen. If you are not careful of the unseen, you will injure the unseen while trying to tackle the seen. You're getting what I'm saying? So you can't proceed without knowing what is behind this curtain called the peritoneum. Okay? If you want to do advanced surgery, yes. For basic surgeries, you don't need probably to go that far. But I'll just give you an example. I mean, 2 days ago, one of our colleagues comes and tells us again, Doc, we have another ureteric injury. From Kenyatta side, I've been told by one of my colleagues who does laparoscopy there, they see ureteric injuries all the time being sent to them following hysterectomy. Now you tell me that you're all laughing and doing this. Now that tells me, my dear, it's just not acceptable. It's just not acceptable. All right? You can't be destroying ureters every time you're trying to do a hysterectomy. It doesn't work. That means those guys are not familiar with where that ureter lies. And if you don't know, then why are we doing that surgery? Right? It's not enough to bring them and say, okay, we'll sort you. Oh, urologist, oh, we'll sort you. I mean, listen, that's not the idea. I kid you not, I've not injured a ureter in my life. And guys, I've been operating for over 25 years. But the issue is, yes, one of my friends told me, that is like your mother-in-law. Take care of that mother-in-law. All right? If you want to stay safe, take care of your mother-in-law. All right? Don't laugh. So when you see your mother-in-law, say, hello, hi mother-in-law, please stay aside, I don't want to injure you. You get my point? Keep them out of the way. But it's not fair that you have so many injuries all the time. That means there's something wrong. There's something majorly wrong. So the only majorly wrong thing is this. You don't understand the anatomy and you're proceeding. You've understood? So you will obviously injure things on your way. Now, topography. Topography is surface anatomy, right? We know that, we learned it. So just for a few understanding, umbilicus is at the level of L3, L4 in most patients, but it can vary with the patient weight, the height, the presence of an abdominal panniculus, the position on the table, whether we are flat or head low, So it can vary, the umbilicus can vary, but this is in a normal situation. The aorta bifurcates around L4, L5 level in 80% of the patients. So you see, you have the umbilicus and the aorta is here. So if you are doing that, you're aiming for the aorta. Right? So unless you know what we discussed when I taught you on how to enter, you're aiming for the aorta and the IVC that is just to the right of it. Okay? You have to know the anterior superior iliac spine levels, and we discussed about Palmer's point and other things. When we go intraperitoneal after the initial entry, we have what is called the superficial intraperitoneal anatomy. So on the anterior wall, so now I'm going in, I'm in the abdominal cavity, we have the anterior abdominal wall. On the anterior abdominal, we have the bladder in front there. From the bladder, you will see a band-like structure that comes up from the dome. It's called the urachus. The urachus in the early stages is presented that way. Next to it, you'll see two folds over the peritoneum called the umbilical folds or the medial folds. These medial folds correspond to the obliterated umbilical artery. This obliterated umbilical artery, when you tug on it, is a continuation of the anterior branch of the internal iliac artery. Okay? So, that is the medial fold. Then we have two lateral folds. So you have the medial, and just lateral to it, you will have two more folds over the peritoneum where you will see a bluish structure and a pulsating structure. The pulsating structure in the middle and bluish structures spanning it on either side. That is now the inferior epigastric vessels. So these are very important landmarks because that is what you're going to be needing when proceeding. So this is the obliterated umbilical artery. Obliterated umbilical artery. In the midline there is a urachus, and you will see the vessels like this. Can you see this vessel? So you have the vessel and the vein on the side. So we have the artery, vein, the medial ligament, umbilical ligament, and the round ligament entering or going out. Now we go posterior. So posterior anatomy. So posterior wall, we start with the midline when you see there. So let's say it's better seen in a thin patient. You won't see it very well in an obese patient. But in a thin patient, you have, in the midline, you will have the sacral promontory, and then on either side. Agreed? So when you go behind down there, you will see the uterosacrals from the uterus. Agreed? So you have the uterosacral folds. Then we go lateral to it. This will be going that way. Just lateral to it, you will see another fold on the lateral pelvic wall corresponding to the ureter, where you will see the ureter, peristalsing in behind it. So that is the ureteric fold. Just above that, you actually have the internal iliac artery fold. Now, it is just slightly lateral to the ureter, but in very thin patients, you might see this pulsation. Then you go above that, you will have the external iliac on the lateral walls. Okay? So you'll see the external iliac, the artery, and the vein is just posteromedial. Okay? It is just posteromedial. Now, one important difference between the right and the left is the ureter on the right crosses over the external iliac. The ureter over the right, on the right, crosses over the external iliac artery to enter the pelvis. On the left, it crosses over the common iliac. So it's a bit high. This is a bit higher than this. You've understood? So that's important again anatomically. Now, see why I am saying these small points. Anatomical surgery. When the pelvis is messed up by a frozen pelvis, this is the key that will tell me where this ureter will be. External iliac on this side, common iliac on this side. Are you now understanding why it's important? It's not to mug up, yeah, this crosses here, this crosses there, here, that. No, it's not for that purpose. This is where I use this knowledge to know, my friend, if this is the ureter, the internal iliac is just lateral to it. The nerve hypoglossal is just medial to it. You get what I'm trying to explain? Now, this is the knowledge we would use to operate in this area in a distorted pelvis. In a normal pelvis, I may not need to go there. Do I make sense? But if I don't know this, I will never approach that area. And the moment I approach that area, without this knowledge, I'm going to be calling somebody every week saying, I'm injured on the ureter. So that's what I mean. It's simple. It's very simple. Okay? Now, we go on. In the pelvic brim, okay, so what is crossing over and what is deep? Okay, this maybe not at the moment. So this is what I was trying to tell you, that they cross over at different levels. Now, what are my concerns when I'm doing surgery in such a complex situation? The first concern is, it's important that I need to know what are the anatomical structures in that my field of dissection. Okay? It's important. Both intraperitoneal and retroperitoneal. But even more important is, how do I safeguard these structures in my field of dissection? Do I make sense? So it's not enough for me to know the ureter is here. It's even more important to know how am I protecting this ureter by pushing it off my field. You getting what I'm trying to explain? So it's important to know where it is. It's more important to know how to protect it. Okay? So in the side wall of the pelvis, the superficial layer actually has the ureter just under the peritoneum. So the ureter, God has created in such a way that He shows us. This is the ureter. You will see it peristalsing up and down. Now, if you can see it, there is no reason we should harm it. We should now know where is this ureter coming too close to me that I could injure it. You get it? And there are specific sites of injury of the ureter that we know, and constantly, even after knowing and learning, we injure it in the same place. So that's what should be avoided. Are we getting it? So that's the most common layer. Just below that, there is a plane that we can dissect this ureter off, the other surrounding structures, that is avascular. So this, you see these two white avascular planes? Those are my areas of interest. That I can dissect it off the internal iliac vessels and the sheath of the cardinal ligament down there without injuring it. Now you're getting my point? My interest is here. My interest is here. Okay? Imagine there was no plane between these two. Then I have a problem. So, what is the key to anatomical surgery? You're looking for those planes where you can operate and separate these things out. These are the spaces that we can operate in the retroperitoneum, that is going to make our surgery safe. Are we understanding? So what I mean by that is these are avascular spaces in the pelvis, potential spaces. It's not like a hollow there. The structures are next to each other, but when you separate them, it's avascular in between. Have you now understood what I'm saying? So we have these spaces, pararectal in pairs, left and right, paravaginal, paravesical, left and right, prevesical, in front, single, pouch of Douglas, behind, single, retrorectal, there's another one that is called retrorectal, or presacral, which is behind the rectum, single. So there are some of these that are single, there are others that are paired. So these are basic spaces that we need to understand. I'm just going to brief you through them. We don't need to learn everything about it here. But my key, reason to explain this to you is, listen, if you want to advance in surgery, then this is mandatory. Advance in surgery. Okay? So advance means you want to do oncology behind there, you have no choice. You'll have to learn these spaces. Okay? You want to do advanced laparoscopic work like endometriosis, you have no choice. You'll have to learn it. You've understood? You want to do simple procedures, it's fine. But again, simple procedures, you still need to know the down there where this structure like ureter is coming close to keep them away. But in advanced surgery, if you want to advance, you have no choice. You'll have to learn these spaces. Okay? So in the pararectal, I'm not giving you again the lecture like the textbooks gives you in grants or choracias that we all learn, that medial margin, lateral margin, base, the floor. I mean, that you can read, guys. I'm giving you clinical aspects and important points that you need to understand, okay? In the pararectal space, again, this is divided into two. We have the medial pararectal and the lateral pararectal. Each of them have their importance. But in this area, as we're moving, it's a space that has one structure that crosses across that area. And that cross structure that crosses, when you're dissecting this ureter away, that crosses now transversely, is the uterine artery. You've understood? So that is important. Secondly, the ureter is always lateral to the uterosacrals. So if you are anywhere medial to the uterosacral, you're never going to touch the ureter. Are we getting this? So these are key small points. If you are medial to the uterosacral, you cannot touch the ureter. You can't. Okay? And as it moves in front, it will continue with the para and prevesical spaces. Okay? So it's a continuous space. So we are talking about the spaces. This space here now is called the pararectal, And we have the internal iliac where it branches, uterine artery branches off from the internal iliac, and it's the only structure that crosses this space called pararectal. And when it crosses this, in front of this is called the prevesical space, the paravesical space. So paravesical, pararectal, separated by the uterine artery. You're getting my points? Now, this area here is what I was talking about, that you need to know so that you can separate the ureter from the vessel. This is the space that is avascular between these two. You've understood? We go on. We have these structures that are in this area deep there, okay? Now, another thing, let's say now we are not going into the depth of the Latskos and Okabayashi space, which is now the lateral and the medial spaces of the pararectal. Okay, each of them have their importances. One is important for the nerve, right? And one is important for the lymph node dissections and all, okay? So, the pouch of Douglas, this lies between the uterosacrals. So I told you if you are medial to the uterosacral, you cannot hit the ureters, okay? Number two, in this area, what is down there is the rectum, agreed? Here you have the uterosacral and the uterus in front of. So this space in between can be separated so that you can go into what is called the Denonville's fascia, the rectovaginal septum. Agreed? So there is a septum between the rectum and the vagina. That septum is again avascular. Now, if you want to stay correctly in this rectovaginal septum, you follow one dictum called fat belongs to rectum. You've understood? So it means when you open that area that is behind the uterosacral here and the fat here, you open it up. When you open it up, you will see fat. That's the first thing you'll see. You will see fat. If you want to stay safe, what do? You go above the fat. As far as you can go above the fat and push everything with the fat down. Don't go into the fat. Are we understanding what I'm saying? Don't go into the fat. If you go into the fat, you'll come across bleeding, and the next thing you know is it's now all messed up. So, principle, fat belongs to rectum, stay above the fat. So you go all the way to the vaginal wall and push everything down. The vagina has no fat. The vaginal wall has no fat. If you know that, guys, it's simple. Why are you dissecting in the fat? Dissect above, leave the vagina, go with the fat down. You're now getting my point. You will never make a mistake. You will never injure the bladder by mistake by going in the fat, and the next thing you know is you're in the bladder, in the rectum. You can't. Go above the fat. Make sense? So this is the two layers of Denonville's fascia, this, and there's fat in between. So to play safe, push the fat down with the rectum. Clear? So this is the rectovaginal space that we were talking about between the rectum and the vagina. Okay? Prevesical space. So prevesical is in front of the bladder. Not many of us need to go into that space. It's mainly a space that is used by urogynecologists, right, for repairs of prolapses and pulling them up and cystocils and etc., etc. Got it? So that space is in front of the bladder. So again, it will always lie between the two obliterated umbilical arteries. So if you see those two obliterated umbilical arteries, you don't go lateral to them. Then you'll hit the inferior epigastrix. Again, you get my point? The logic is simple. The bladder is going to be only between these two. So you open it here, go in and push the fat down. Fat belongs to the bladder. Again, fat belongs to bladder. Fat belongs to rectum. Okay? So if you see fat there, push the fat down with the bladder and you will go to the bladder safely. You go into the fat, you're going to hit the vessels, you're going to hit the bladder wall, and you're going to start bleeding torrentially. Bladder is very vascular. Okay? So you don't want to do that as well. Fat belongs to bladder. Same thing with the UV fold, utrovesical fold, even in cesarean guys. It doesn't matter. 3 scars, 4 scars, 5 scars, 7 scars over the bladder. I don't give a damn these days. To me, it doesn't make a difference how many cesarean sections have been done before. You get my point? With the specific anatomical knowledge, I will be careful enough not to get into the bladder. So again, fat belongs to the bladder. Secondly, whenever you have the multiple scars, what is going to happen is, let's say this is the uterus, okay, and the bladder is here, right? Agreed? This is where you do your cesarean. Agreed? The adhesions will always be messed up here. The bladder will be pulled up. Agreed? This makes sense, guys? Here, there is no adhesion. Here, there is no adhesion. It doesn't matter how many cesareans have been done. Am I making sense here, guys? So what I'm trying to explain to you is very simple. This is called the lateral window approach. So what do we have here? This is now a very big uterus. It's a pregnant uterus. But now let's make this uterus smaller. Let's say make this uterus like for a hysterectomy. Okay? You agree this is the round ligament and the round ligament. Got it? So when you open this in front of the round ligament here, then you start dissecting in that direction. Don't ever attack the adhesion. You attack the adhesion, you go into the bladder. You've understood? And yes, I mean, we have very good reasons to say, yeah, bladder was injured. Yeah, there were multiple scars. It's okay, it happens. We are so happy saying that. Why are we not happy trying to avoid it? All right? Why are we trying to justify why we injured the bladder? Am I making sense, guys? I mean, we injure the bladder and then we say, yeah, but it was multiple 4 scars. Hey, Bana, this bladder was baya, my friend. There was no way we could have escaped it. I mean, seriously? So you see, you justify and you make yourself feel good and everybody else say, yeah, I know, man. Congrats, man. I mean, you repaired it. Why not avoid it? So learn tactics to avoid it. Don't learn tactics to justify why it was injured because it was very badly adherent. Am I making sense here, guys? So this is where anatomy helps you. So the adhesion will always be here. Now, the adhesion will also not be here. So what I mean is, now let's say on the side now. So this is front view. You've understood? It is central. This is now the bladder. Make sense? The adhesion is here. Am I clear? So even here, this part does not have adhesion. So just above the adhesion, there is a space there that has no adhesion, both laterally and inferiorly. Am I now clear? Because adhesion will always be where you operated, and now the cesarean scar is where this thing goes and sticks to it. Am I clear, guys? This is important knowledge for you because you also do lots of cesareans. All right? So guys, I don't want to hear a single cesarean bladder injury from this group now. I mean, make it a point. Because it doesn't happen with me, so it's possible. You've understood. When you see it's badly adherent, you approach it differently, is all I'm trying to tell you. Don't approach it head on into the adhesion. However good you are, you will open up the bladder if you're not careful. So approach it from places that you know hakuna adhesions hapo. So that's called the lateral approach. So you see what I was trying to show you? I was showing you approach it open here and approach it this way. Now, inferior here is here. So I'm going laterally and now I'm opening here. I'm pushing the bladder up, I'm pushing the cervix down. I'm pushing the bladder up, I'm pushing the cervix down. I'm pushing the bladder up. Once you have done that, I'll have the bladder in front here that is free from the cervix, and I'll have here where it is stuck. Now I approach and open this part up. Have you understood? This is called the lateral window technique. You have to learn the lateral window technique for adherent bladder. Are I clear? If you do that, you don't injure the bladder. Okay? So don't justify why a bladder is injured. Try learning how to avoid a bladder injury. Okay, guys? So we are now going further. Uterine vessels. I mean, this, you guys all sing, you know, but maybe I don't know if you have gone and seen this anatomical relation directly, but yes, in laparoscopy, we can easily show you this anatomical relation, where we say water goes under the bridge. Yeah, you know that, but how many times have you seen that water go under that bridge? Well, in laparoscopy, we show you. Okay, I can show you the water going under the bridge, which means the uterine artery and the ureter, like this. So, got it? But the knowledge has now changed after laparoscopy has advanced. The ureter does not lie just below the uterine vessels. Wrong. The ureter lies below the uterine artery and above the uterine vein. The ureter lies between the fork, in the fork between the artery and the vein, which means you cannot take both the artery and the vein with that ureter in between. You'll have to separate them properly first. Otherwise, you take it like this, artery and vein, ureter katikati. Make sense? So, the ureter goes in the fork between the artery and the vein. But yes, the artery goes above, so water below the bridge. Okay? So this is how they cross over, for example, but now lymphatics, yeah, I mean, these follow the veins. The dissection is, this is usually important for our oncology colleagues. So you have to always understand which nodes are important for which kind of disease. That's not what we are covering today. Vesicouterine tunnel or the vesicouterine ligament is where the ureter goes all the way in, and then there is the knee of the ureter where it will first go lateral and then medially turn medial, then go over the anterior vaginal wall to enter into the trigone, right? So that is important for you to understand. The ureters go like that. Just turn lateral, medial, anterior. So, if you know that knowledge, again, use it to avoid injuries of the bladder. Okay? Never go that deep down there. Because when it's doing this, this is the cardinal ligament. So when it's doing this, this is the cardinal ligament. This is where people grip it. That is where people grip it. Okay? So you have to understand how not to injure it. The tip there, number one, elevate. Which means if you push the uterus in, if you have an elevator, or if you pull the uterus up from in an open hysterectomy. But I know majority of you, if you are doing, you'll be doing open hysterectomies or assisting in open hysterectomies. When you pull it, you are leaving the ureter there and doing that. Then you cut here, it's fine. If you leave it this way, these two are too close together. You do that, pop, ureter imeenda. You've understood? So, key number one, lift up the uterus, so that you leave the ureter behind. Am I clear on that? Good. So that's one of the tips you can use. Obviously, the second tip is to be able to, identify it and lateralize it as you cut it, but I don't think everybody does that. Okay? Nerves, we have the obturator. These are important nerves for us in gynecology. genitofemoral, which lies over the psoas muscle, the pelvic splanchnic nerves, which come down there to make the hypogastric, inferior hypogastric plexus, the hypogastric nerves, which are the sympathetic component of the hypogastric plexus that go on either side. They are just inferior and medial to the ureters. So you have to be careful. If you damage this, you're going to cause neurogenic issues with the bladder, the rectum, and sexual function, okay? And then the plexus. So we have to remember this, but the key points again for advanced surgeons is the landmark for the inferior hypogastric plexus is that deep uterine vein. The deep uterine vein, you have to be extremely careful. It is the one that when you're dissecting anywhere there, you're very close to the inferior hypogastric plexus, okay? So nerves we have said, we have discussed where they are. Vascular. So in vascular we have two major vessels that are important to us in the pelvis. So aorta breaks into two, the two common iliacs, okay? The two common iliacs break into the external and the internal iliac. The external iliac, good for us, runs on the lateral pelvic wall and goes out, and just before its exit and its conversion into the femoral artery, it will give up some branches. The most important one of that for us is the one that comes up on the anterior abdominal wall, which is called the inferior epigastric. But apart from that, there is no branch of importance to us in the pelvis from the external iliac. So we are safe there. Internal iliac, soon after it forms, it has a trunk that breaks off called the posterior trunk, and then it has the inferior trunk that continues. Got it? So the anterior trunk is the one that's of clinical importance to us, because that's the one that comes in the area of our surgical. The other one goes posterior, and we will now lose it. Okay? So it's not very easy to injure the posterior trunk unless you're really looking for it. So the anterior trunk, now it's important. We need to know what its branches are. So posterior, you can see it has iliolumbar, lateral sacral, and superior gluteal, but these are away from us. But the anterior trunk gives off 4 visceral branches and 4 parietal branches. These are important. I think this is a question that can come your way. This is a very important question for postgraduates. So the most important ones of these, to us, is the uterine, the superior vesicle that just goes a little in front of it, the middle rectal, okay, and these other ones are the lateral ones that go down there. So you need to know the uterine, the superior vesicle, the medial rectal, okay? Now, some important points about this anatomy. Number 1, the first important medial branch of the internal iliac artery anterior trunk is the uterine, okay? And it almost branches off 5 to 6 centimeters from the origin of the internal iliac artery. So this point is an important place for you to do internal iliac artery ligation, should you have to. So in very bad PPHs, we sometimes have to resort to internal iliac artery ligation. Make sense? When you have to do that, then you have to open up the internal iliac artery, okay? Make sure you go beyond the branch of the posterior trunk. So don't cut before the posterior trunk takes off, because then you will devascularize the gluteal area, which is again going to be a problem. So you don't want to do that. You go beyond the branch. So I told you within a centimeter or 2 it branches off the posterior trunk. So then you go beyond that centimeter or 2, but before the uterine artery, and clamp it there. You've understood what I'm saying? So that is anatomically important for us. Internal iliac artery ligation. If you can go all the way to the uterine artery and ligate the uterine artery, even better, because now you're going very specific. But if you can't, then internal iliac artery ligation. Okay? External iliac artery and vein have no branches or tributaries in the pelvis. Important for us to know. The last branch of the internal iliac artery in our field of vision, before it changes into the anterior umbilical ligament, you know, the medial umbilical ligament, which is the obliterated umbilical artery, is the superior vesicle. Are we clear? So uterine artery, superior vesicle, obturator, interpudendal, blah, blah, they are all going this way. All right? So medial rectal goes behind. It's a posterior branch of that trunk. But after the superior vesicle, this becomes a cord-like structure called the obliterated umbilical artery. Clear? So when you tug on the obliterated umbilical artery, if you can't identify any anatomy, this is where we use that knowledge. We'll go and tug it, and now we are looking down, and you'll see this structure moving like that. So you'll say, oh, so this is the internal iliac artery. Are you getting how I'm using the knowledge to help me? Because when it's a mess, you can't see the internal iliac. You can't see these things. It's all plastered with frozen pelvis. So you use this, and then you say, okay, this is internal iliac, open. The uterine will be here. The ureter will be just medial. You're getting what I'm trying to tell you? So you know the ureter is just medial to that. So if you can't identify, you use this type of knowledge to know where you are. Once you orientate yourself to these major anatomical structures, then proceed. Don't proceed without. The next thing you'll know is you'll have hit the internal iliacs. It's not fun. People say accidents happen. Accidents happen when you're also a careless driver. If you are careful, you get what I'm trying to tell you. In driving, you can say, yeah, I was careful, but the Matatu guy came to me. You can't say that in anatomy. I was careful, but the uterine artery came looking for me. It didn't come looking for you. You went to it. You get my point? It was where it was. It is not moving from where it is. Are you getting my point? So guys, if you are careful, you will avoid it. If you are a careless driver, you will injure them. Okay? I told you the uterine artery, ureter lies in the fork between the artery and the vein. And the uterine artery vein, deep uterine vein, is the guide to the hypogastric plexus. Remember? So we are not going into that. The ureter. I told you my friend said this is our mother-in-law. So this one is what we should take care of very carefully. Okay? Don't fight with mother-in-laws. All right? So it's the longest structure in the abdomen. It enters the pelvis at the pelvic brim. It crosses differently from the left and the right. I told you the right crosses over the external iliac, the left crosses over the common iliac, remember? So I'm giving you important points. Again, I'm not going into its blood supply is this, it's this. You see, those are knowledge you will pick. I'm giving you anatomical importance knowledge, surgically, okay? It always is medial to the internal iliac artery's anterior trunk. So if you know where the anterior trunk is, you know the ureter cannot be here. It can only be here. Are you seeing why it's important? So this is how you look for these structures, okay? There are 3 or 4 major areas of injury in the ureter. Number 1, near the IP ligament as it's crossing over. So if you are doing a total abdominal or laparoscopic hysterectomy with bilateral salpingo-oophorectomy, which means you're also removing the ovaries, then you see you'll have to cut the IP ligament. If you're going to cut the IP ligament and you're not careful, then that's where you hit it. If you're too high up, you will hit the ureter at the IP ligament, where it's now crossing over the vessels. Got it? So that's one point. The second point is where the uterine artery is crossing it over, that water under the bridge level. That's another place where you're not careful, you will go for the uterine artery too lateral from the ureter, from the uterus, and you will hit it there, where it's crossing. Got it? And the third one is near the uterosacrals and the cardinals down there, where I told you it enters that tunnel and where it is now having the knee joint. I told you where it's doing this, hapa. Where it's doing this, hapa. You'll hit it there. So these are the 3 points. If you know these 3 points, those are the 3 points where you become extra careful. All right? And you say, where are you, mother-in-law? Here I am. Okay, careful. Simple. Because those are the 3 you will not injure it in other places. They stay away. But here they come close to you. Got it? They have a poor vascularization, but they have a very good arborization of vessels over it. So in the adventitia. So what do I mean? I mean this. So again, anatomically important. Ureter. Got it? Ureter. Adventitia. Adventitia. Okay? Along the adventitia, vessels. Lots and lots of arborization. Blood supply, one here, one here, one here. That's it. Are we understanding this? So, this is the blood supply from a vessel that is coming to the ureter. But for all this segment, there is no blood supply. But there is a lot of arborization over the ureter in the adventitia. So if you see a ureter, you will see the ureter with capillaries on it. And then you will see this ureter peristalsing. But it will always peristalse inside like this. You'll see it do this. So there is a layer under which you will see it peristalse. That's called the adventitia. And it's on this adventitia that these vessels are. Are we getting my point? So, you cut this, no problem. You cut this by mistake. No, I'm not saying you aim for it. No problem. Why? Because this one is providing blood supply here and it's going all the way on the ureter. Are you getting? It's not that easy to devascularize the ureter by injuring a blood supply that it's having blood from. But it's very easy to devascularize it by damaging this adventitia here. Only that part. That even if it's a centimeter, you have damaged the vessels in the adventitia. There is no connection between this and this anymore. This part will slough off, whether you like it or not. You've understood? It will undergo sloughing, necrosis, and it will leak. Now you're understanding the whole point? So, the key area about anatomy, about ureter, is don't be afraid of this or this, but be very afraid of that. Be very afraid of the arborization vessels on the adventitia. Be very careful about the adventitia. So, my point that I was putting forth here, again, anatomically, this is the important things. That there are only maybe four or five major vessels that actually give blood supply to the ureter. The renal artery, you get it. The iliacs, internal iliac, the uterine gives it, you get it. But they have a lot of arborization in the adventitia. So the most important thing is make sure that this adventitia stays intact. If the adventitia stays intact, the blood vessels, the blood supply stays intact. You lose the adventitia, you lose the ureter. Got it? So when dissecting the ureter, you have to dissect it always with that adventitia intact. Are we getting it? Second thing, it is very important to dissect the ureter and learn how to dissect the ureter for every advanced surgeon. Okay? There is something called the medial approach, called in endometriosis. So we use the medial approach, or we lateralize the ureter in medial approach. Right? And for oncology, they use the lateral approach and they medialize the ureter in oncology because they want to go for lymph nodes and those things there, and they want to take the parametrium there. You've understood. So there is lateral approach and medial approach. Are we clear? So I think, yeah, there was two more points there. So you need to know how to dissect these ureters away from your field of vision in either the medial or lateral approach. Thank you. Any questions, guys? If you don't ask questions, it will mean I don't know. But I hope, you see, I hope I made some sense on the anatomy class. It is to give you hints that you can use even for your open surgeries on how to approach these areas and avoid injuries. You get it? It's not, learning margins, boundaries is important, but guys, it's not going to be used, it's not going to be applied in your surgical knowledge or your skill. And whereas what I was trying to discuss here was to give you surgical aspects to every anatomical landmark. You've understood why or how do you avoid it, how do you safeguard, how do you protect this area, how do you identify so that how do you proceed when there is nothing in front of you that you can see? You can still proceed. You can still proceed if you know anatomy properly. You get it? So that's what I'm trying to explain. Okay, guys? Any questions? I think we are done with anatomy. Now, I don't know what else is remaining. We have hysteroscopy. You guys are keen on the hysteroscopy talks? So we'll cover hysteroscopy. I know there might be one or two other areas of importance, but we'll be discussing that as we move on. So maybe next visit, we'll do a few hysteroscopy talks. Okay? Good. Any other questions, concerns? Yes, Shivani? No.
The next one is hysteroscopy.
It is hysteroscopy, yeah. So we'll follow up on hysteroscopy. All right? So, thank you guys. Yes.